Thanks for the opportunity to present the work that I've done on my PhD to date, and also to Askin for funding my scholarship. So this PhD really sits within a knowledge translation framework, and the title is Towards Better Management of Obstructive Sleep Apnea. I've been enrolled for about a year, full-time equivalent, so I'm going to present some of the work that I've done to date and the plans for the future for the next couple of years. So to cut to the chase, what is obstructive sleep apnea? For those who don't know, it's a condition, a repetitive closure of the upper airway during sleep, so an obstruction or a collapse of the upper airway that occurs during sleep, which causes a cessation in breathing for a minimum of 10 seconds. It's associated with a reduction in oxygen saturation, and it's usually associated with an arousal from sleep, which is like a mini wake-up that the person is usually not conscious of. So this process occurs repetitively throughout the night and leads to an unrefreshing night's sleep, and usually to daytime sleepiness. So why do we care about it in spinal cord injury? So first of all, it's highly, highly prevalent in spinal cord injury. So our best estimates put the prevalence between 28 and 77%. So obviously that's a very wide range, which can largely be explained by the quality of the studies that have been done. So there's a huge amount of heterogeneity in study design. But certainly the more well-designed studies put the prevalence up the higher end, around the sort of 70 to 77% rate. It's thought to be caused by the spinal cord injury itself for factors that we're still uncovering. But we know it's associated with both substantial neurocognitive impairment, so impairment with memory, learning, thinking, concentration, information processing, and also a reduced quality of life in people with tetraplegia. We also know that it increases risk of cardiovascular disease, diabetes and premature death in the able-bodied, and there's no reason to believe that this would be any different in spinal cord injury. In fact, it's likely to probably be worse. We don't know a lot about how this condition is being managed in spinal cord injury, but one study in the States following a veterans population after a review found that only 14% had been diagnosed with obstructive sleep apnea, so obviously much lower than what we would expect. And of those diagnosed, only about 50% were receiving some form of treatment. So there's a large burden of disease that's being underdiagnosed and untreated in this population. There are no studies that systematically describe what the current management of OSA in spinal cord injury is, nor what influences those clinical decisions that the medical staff and others make. And one of the questions of my PhD is aiming to address this. So there are two clinical practice guidelines currently in circulation about how to manage OSA in spinal cord injury, and they generally recommend polysomnography to diagnose sleep apnea for those people with symptoms of sleep-disordered breathing, and a prescription of positive airway pressure or other therapies if it's diagnosed. So what is polysomnography? It's basically the gold standard method for diagnosing obstructive sleep apnea or sleep-disordered breathing, including obstructive sleep apnea. It's a multi-channel device, and this is obviously a setup of one here, which takes a recording of the many physiological changes that occur during sleep. It's a highly specialised and expensive test. It usually requires the person to go into a sleep laboratory and stay overnight, which is obviously incredibly difficult if you are in a chair. And it's also expensive because it requires a sleep scientist to set up and analyse the data, and a sleep physician to report the study. Most spinal units around the world don't have access to these kind of tests, and so in fact with our COSAC trial, which is a large RCT that we'd just finished around treatment of OSA in acute spinal cord injury, we had 11 sites around the world, and only half of them had access to sleep services, and this is in highly developed countries, so it's pretty inaccessible. These are what the data look like that come from polysomnography. So I'll just quickly run you through it. So up the top here, we have those different colours represent the different stages of sleep. So that is an entire night's sleep that you can see there. However, this is a 30-second window and this is a 5-minute window. So across the top here are the EEG traces, so that's the brain waves. And you can see that in a couple of places here, there are a couple of arousals from sleep. If we move down to the bottom pane here, which is a 5-minute window, that's the oxygen saturation along there, and here we have airflow and respiratory effort. So you can see that in this 5-minute window, there are 4 respiratory events where there's been a complete cessation of breathing for more than 10 seconds that are associated with a reduction in oxygen saturation and a couple of arousals from sleep. So at the end of this sort of analysis process, a number is spat out, which is called the apnea-hypopnea index, and that is a count of the number of respiratory events that you have per hour of sleep. And there are different thresholds for diagnosing sleep apnea with this particular score, and also the severity of the sleep apnea. Okay, so in response to the poor limited access to sleep services and polysomnography, there have been many questionnaires and clinical prediction models or alternatives developed and tested to try and to find an alternative for PSG in the able-bodied. These 3 papers here are all systematic reviews, and all of them concluded that these alternatives tend to be good at predicting severe obstructive sleep apnea but miss a significant proportion with mild disease. Only 2 questionnaires have been studied in tetraplegia to date. Both only looked at identifying OSA or not, so it didn't look at sort of severity of OSA, and both performed poorly. So more recently, some colleagues of ours in South Australia have developed a 2-stage screening model for detecting moderate to severe OSA in a primary care able-bodied population. So the 2 stages are: the first is a simple 4-item questionnaire, which asks about obesity, snoring, apneas or breathing cessations, and age. And this first stage gives a score out of 10. The purpose of the first stage is to rule out the need for further testing, and a score of 5 out of 10 or higher means that you need to go on to have overnight oximetry, the second stage. A score of less than 5 out of 10 assumes that you don't have moderate to severe OSA, and therefore you don't need to go on to the second stage. Those who do have overnight oximetry, where they get an oxygen desaturation index, which is the number of times that your oxygen saturation dips by 3% or more in an hour, and a score, according to this model, a score of greater than or equal to 16 will diagnose moderate to severe OSA. So this model performed really, really well in the able-bodied population and was published in Thorax. So the objectives of my initial research is to determine whether this same 2-stage model that is being used in the able-bodied population can predict moderate to severe OSA in chronic tetraplegia. And secondly, whether we would be able to modify the questionnaire so that it is more specific to people with tetraplegia, with the risk factors that we know affect them, and whether this will improve the accuracy of the model. So I was lucky enough in our lab, we had a data set of 78 people where, for some previous research, we had collected a battery of demographic, sleep and quality of life questionnaires, and we had full overnight polysomnography on these people, including oximetry. So all the data I needed to validate the model. I was able to derive the OSA 50 questionnaire from these questionnaires up here, automatically calculate the 3% ODI from the oximetry, and compare the 2-stage model with the gold standard PSG. So what I did was assess the 2 stages independently using ROC curve analysis, and I'll show you that in a minute, and then the 2-stage model overall with sensitivity and specificity and other predictive values. So these are the results of the OSA 50 questionnaire. So for those who don't know, this is an ROC curve. The purpose of an ROC curve is to assess the accuracy of a diagnostic test. And this area under the curve here, so the greater the area under the curve, the better the test. And a score of 1 indicates a perfect result, and a score of 0.5 is no better than chance. So the OSA 50 actually scored very well, and it was, I think, 0.82 in our sample and 0.84 in the able-bodied sample. Over here we have sensitivity and specificity. So for those who don't remember in their uni days, the sensitivity is the proportion of true positives, so those who are accurately identified with the disease, and specificity is the proportion of true negatives, so those who are accurately identified as not having the disease. And and so you get a sensitivity and a specificity for various cutoff points. So the cutoff point of the purpose of the first stage of the two-stage model is to rule out the need for further testing. So we want as high a sensitivity as possible. And the score of greater than or equal to 5, as it was in the able-bodied, didn't have a high enough sensitivity. We were going to lose people. So we adjusted the score to be greater than or equal to 3 out of 10 for our population. The second stage model, separately again, looking at overnight oximetry. The area under the curve here is 0.95, which is the same as it is in the able-bodied. So it's a very accurate way of diagnosing moderate to severe sleep apnea. And the purpose of this stage is to kind of get an overall accurate measure. So we need to trade off sensitivity and specificity and maximise them both. And so with the score in the able-bodied of greater than or equal to 16 had too low a sensitivity, and so we adjusted the score again to 12. Okay, so I'm now going to report on now we put all the data together in the two stages and gave everyone a score of whether or not they had OSA. So we have sensitivity and specificity of the Chai-Kotzer, so the original able-bodied validation, so sensitivity of 88 and a specificity of 82. When we ran that model with their cut-off scores, so the cut-off scores for the able-bodied, we lost a lot of sensitivity, so down to 77, and gained some specificity. However, with the adjusted scores that were optimised for this population, we actually had a really good result. This needs to be validated prospectively, but the model seems to be performing very well. So down the bottom here is the percent that require oximetry in the two-stage model. And so obviously the purpose of the first stage is to rule out the need for further testing. And in the original able-bodied population, they were able to rule out the need for further testing for 26% of their population. However, with our optimised scores, we're only ruling out 17%. So in the prospective validation, we'll be looking closely to see how this plays out and whether it is in fact worthwhile doing a questionnaire or whether we just jump straight to oximetry. So the second part of the study was to look to see whether we could improve the performance of the questionnaire by looking at specific risk factors in spinal cord injury or tetraplegia. In the literature, these are the known risk factors that have been published, and luckily we had collected all of them in this previous study, so I was able to look at all of them individually and in a multivariate analysis to look to see and to develop a new questionnaire that's based on the coefficients of the multivariate model. So I'll talk you through that. So the purpose of the questionnaire is to be something that's very simply administered in an outpatient setting. So we needed to ask yes/no questions, and for that reason I needed to dichotomise all the data so that it could be yes or no. I'm not going to talk you through how I did that in the interest of time, but here are all the risk factors here. And you can see with these p-values that all of them except for medications were at least mildly predictive of obstructive sleep apnea with a p-value of less than 0.1, which was the criteria for entry into the multivariate model. However, 3 of them were kind of measuring the same thing. So neck circumference, BMI and waist circumference are all generally measures of adiposity and would be highly collinear. So we therefore could only select one, and we selected neck circumference because BMI and waist circumference are very difficult to measure in this population, to easily measure in an outpatient setting. So 7 variables were entered into the multivariate analysis, and 5 remained significant. So having an Asia impairment score of A, B or C, reporting apneas, reporting snoring, having a daytime sleepiness, so a Karolinska sleepiness scale score of greater than 3 out of 9, which is a scale that asks how sleepy did you feel at midday today on a scale from 0 to 9, and whether or not the person's aged 40 or over. And the odds ratios here are all kind of fairly equivalent, so they're all around about 2, and so therefore they all weighted evenly on the new questionnaire. So we've basically got 5 risk factors and a score out of 5. So I rescored all of the 78 people that we had in our data set and reran the analyses. And this questionnaire performed really well. So we had an area under the curve of 0.89 and a score of greater than or equal to 3 out of 5. So if you had 3 of those risk factors out of 5 or more, then you went on to the second stage of testing. Okay, so this is the same table I presented before, but now with our new model over here. And this performed really, really well as well. So almost the same as the able-bodied model with the optimised cutoff scores. So we're now running a prospective validation of this to see which one holds up. But the other interesting thing to say is that we're able to eliminate 37% of the population in this study for which the questionnaire was developed for overnight oximetry. So very keen to see if that holds up. By contrast, just doing an oximetry alone, so obviously 100% of people undergoing oximetry, performed almost the same. So basically what I've described there is that if you score 0, 1 or 2 out of 5 in the new questionnaire, which we've called TOSAC, I didn't explain that, tetraplegia OSA questionnaire, then we're pretty much saying that we are assuming you don't have obstructive sleep apnea and you don't need further testing. One person failed this test. But what's interesting is that we may also, depending on what our prospective validation shows, if someone has 5 out of the 5 symptoms, then they may not need to go on to have further testing either, because we can assume that they actually have the disease. And this one person failed that test, however, he had mild OSA, so could benefit from treatment anyway. So, as I said, we're doing a prospective validation of both the able-bodied model and the new improved tetraplegia model. We're aiming to recruit 150 people. I've started recruiting at the Austin. We've received a grant from Stoke Mandeville in the UK, and they now have ethics approval and are just getting organised to start recruitment, and likewise at GF Strong in Vancouver. My supervisor, David Berlowitz, is also on a US Department of Defence grant, which is an RCT of CPAP in chronic tetraplegia, and they're collecting all the data that we need for our validation, so they'll be providing some of the data as well. So by this time next year, I will have the results of the prospective validation. So just quickly, I'm not only going to touch on this, but the second component of my PhD is about asking what is happening in the current practice in the identification and management of obstructive sleep apnea and tetraplegia, and what are the factors that influence that practice. So obviously, not obviously, but this is the first stage in any knowledge translation program. So if you're wanting to improve practice and design an intervention to improve the management of a condition, you kind of need to know what's happening on the ground before you start. So the first thing I'm going to do, and my ethics application is in, and I'm hopefully going to start recruiting early next year, is to conduct some in-depth semi-structured interviews with physicians who are managing people with tetraplegia. And the interview questions are going to focus on asking them to describe how they actually manage this condition, and using a framework called the Theoretical Domains Framework to identify what factors are influencing their practice. So the Theoretical Domains Framework is a set of 14 constructs that are known to influence clinical behaviours. It's widely used in knowledge translation research to assess why people are doing what they're doing, and to help to develop interventions to improve clinical care. So after the qualitative interviews, I'll be using the results to develop a quantitative survey asking similar questions but to a broader range of spinal clinicians around the world. And I also plan to audit some medical records in a few units where I've done the qualitative interviews to kind of, I guess, assess or validate what the clinicians are telling me they're doing with what is actually being recorded in the medical records. Okay, so final slide. What we're aiming to achieve with this project is hopefully an accurate, simple and accessible screening model for moderate to severe OSA in people with chronic tetraplegia that will potentially contribute to clinical practice guidelines in the future and increase the screening and diagnosis of OSA and spinal cord injury. And a better understanding of current practice and the factors that influence current practice, so that eventually we can develop targeted interventions to improve clinical practice. And just acknowledge my fabulous supervisors, to Askin, not Skin, sorry Chris, and for the PhD scholarship, to also TAC, who have funded a lot of our research in the past, and this is an extension of that really, and also to the 2 funders overseas. Thank you.